esophageal motility testing and function testing. So it's a pleasure to welcome here today, and we're going to get a second dose of Dr. Pandolfino later this afternoon.
Well, thank you very much. Not often I get an opportunity to indulge myself and talk about the future of esophageal function testing along with the state-of-the-art. And the stuff I'll be presenting today will be state-of-the-art, stuff that you can use day-to-day practice, but I'll also talk a lot about the future and a lot of the opportunities we have using machine learning and artificial intelligence and in silico models to improve our understanding. Let's see here. Now I'll go use this. It's not going forward. Oh, there we go. All right, so the goals of my talk today are going to really focus on discussing important technological advances in esophageal function, specifically focusing on dysphagia, but we will certainly talk a little bit about GERD. And what I'll do today is also review the Chicago Classification 4.0, but also talk about where we're going with Chicago 4.0 to 5.0, especially with the introduction of impedance. I'll talk a little bit about flipped phonometry, and before I go any further on that, I will tell you that I do have a conflict with that. That was actually a technology that evolved in our lab, and we do have patents and licensing agreements with Medtronic. In addition, I'll also talk about how in silico modeling and machine learning can improve our understanding of esophageal function testing, in particular when we focus on esophageal reflux and also dysphagia. So one of the things that I'm always struck by with the esophagus is that when you think about the symptoms you encounter in the esophagus, heartburn, regurgitation, dysphagia, chest pain, and food impaction, when you sit there and try to get that history in your clinic, you know, the differential diagnosis for all of that can be quite varied. So when you think about that, the most common thing most likely could be GERD, just based on pure prevalence, but certainly you're thinking in the back of your mind, EOE, maybe this is a mechanical obstruction, could this be a motility disorder or a functional disorder? And I always joke around that no matter how good a clinician I feel I am and how much I want to impress the medical students, residents, or fellows who are with me in clinic, a lot of times I'm wrong. And that really comes to the point that when you're looking at these particular disease states, essentially all roads lead to endoscopy. And that's a point that I really want to make clear, is that endoscopy is still probably the most crucial diagnostic test that we use in esophagology. It's extremely important and really the primary thing that we want to do. We want to rule out obstruction, mechanical obstruction, because we can do something about it, and also make sure they don't have something bad. So that's why I put up this algorithm. So this is the actual Rome 4 diagnostic algorithm for dysphagia. And you could put whatever you want there. You could put the algorithm for GERD, chest pain, reflux sensitivity, sometimes even globus. And regardless of how you do that, you will always wind up starting with some type of endoscopic imaging. The caveat is that if I see people with globus, a lump in the throat, I typically have an ENT doctor see them first to evaluate and make sure I'm not missing something in the oral pharynx. But that being said, all roads will lead to endoscopy. And in that, when I'm looking at the patient, I'll certainly go through the endoscopy looking for specific things, esophagitis. Now, if I see Los Angeles C or D esophagitis, I'm done. I know what the issue is. I'll look for a stricture and dilate that stricture if I find it. I'll certainly biopsy patients for eosinophilic esophagitis. And I will tell you that although we're taught that 10% of EOE can happen in the context of a completely normal endoscopy, I think in retrospect, when you go back and look at those patients, especially after you actually do that biopsy, you can start to see the furrows, and it's less likely. So I still do that, but I don't know if that's necessarily true that 10% of those people have a completely normal endoscopy. I think it's just basically a normal endoscopy overtly. And then the other point is hiatus hernia. I think this is something that gets underreported and under-recognized as an important component of esophageal symptoms. Often I get a case where I get a normal endoscopy back and I get a second opinion referral. I scope the patient, they have a 2 or 3 centimeter hernia with a flap valve of 3+. And then this patient is complaining of regurgitation or dysphagia, and that in and of itself could explain that. We've known that for quite a long time, especially from our radiologists, that hiatal hernia is a very significant mechanical abnormality. So when you see that, I always teach my fellows, respect the hernia. Because if everything is negative except for that hernia, it's probably a hernia causing that particular problem in the esophagus. Now, of course, if the endoscopy is negative and you're seeing these patients, your top 3 diagnoses are almost always GERD, GERD, and GERD, right? I would actually say it's probably GERD, GERD, and functional esophageal disorders. But that being said, this is how we go through this. And in my practice, what I typically do is, if I'm suspecting GERD, and I have no idea whether they have GERD, they don't have a history of esophagitis, Barrett's, they don't have a previous positive site, I make sure that they're off medication, and I do a wireless pH capsule off medication for 96 hours. Because that gives me the best bang for my buck to say whether or not this person has reflux, yes or no, and grade severity. So if it's 4-day negative, that patient does not have reflux. They either have a functional disorder or a motility disorder. But if they do have some evidence of abnormal reflux exposure or acid reflux exposure on that wireless capsule, these are the patients I may think a little bit more carefully about, grade their severity, either send them for pH impedance on medicine, depending on where I'm at, looking for belching disorders, rumination, and so forth. So really a fork in the road there. Well, what about motility testing? Well, this was really a major evolution over the last 15 years now. I used to say 10 years, now it's 15 years that this technology has really evolved. And this was really most notable for Ray Klaus, because Ray Klaus was really the person who put together these Klaus plots. And what he did was, he took all of this information from conventional manometry and turned it into color topography. And in doing this, he gave this beautiful representation of a swallow where you could actually see manometric anatomy, the upper sphincter, the lower sphincter. You can see this beautiful seamless peristaltic event. You could even make out the striated muscle esophagus from the smooth muscle esophagus if you carefully assess this. So really a wonderful evolution with these beautiful images. And this technology really did change what we did. We were able to now talk a specific language. It was much more reproducible amongst investigators. And there were clinically relevant phenotypes that came out of that, in particular the achalasia subtypes, where we could actually see that there were some subtypes that would have a good prognosis and some that would have a bad prognosis. So this really was an evolution, but it was not perfect. And that's where the Chicago Classification 4.0 came into play. And I will say that the primary goal of 4.0 was to correct the mistakes of 3.0. Because one of the disease states that came out of the 3.0 era was EGJ outflow obstruction, which for most respects is not actually a motility disorder. It usually is either an artifact that you find because of a catheter issue or potentially an anatomical issue related to a small hiatal hernia. So one of the things that Chicago 4.0 did was to actually reconfigure things and give a much more robust and restrictive definition to convert things into either inconclusive motility or conclusive motility disorders. So really what we saw was this requirement of further testing when you saw some of these inconclusive findings. It did also expand our protocol, which I always thought was important. I think just relegating things to 10 supine swallows was not enough. I see a lot of patients that I give a solid meal and then I see a beautiful obstruction. So once again, that was another evolution that I think was important. There was also some question. A lot of people were fearful that we were getting rid of ineffective esophageal motility, so we brought that back. We just made it a little bit more restrictive so that it had clinical relevance. It was actually at a state or range where we would see much more severe dysphagia and acid exposure. And then, of course, I think the introduction of these EGG metrics, which a lot of people really missed with motility interpretation, I would still interpret the EGJ and give a lower esophageal sphincter pressure in my reports, but it was really never part of the definitive Chicago classification. Now, I will tell you, here's the algorithm for CC 4.0, and I'll tell you that I really don't look at this. When I actually do manometry, I look at the patterns and the topography plots. And I don't go through these particular models and take all of these measurements. And I think really, if you think about it, a picture's worth 1,000 tracings or a picture's worth 1,000 measurements. And pretty much when you open these studies now, you can pretty much get the answer as soon as you see these particular studies. Now, as I mentioned, though, we did expand the protocol. So if you are doing manometry or motility testing, or you're referring people for motility testing, you shouldn't just rely on those 10 supine swallows because we know that that can trip you up. Certainly when you change position, it can change the measurements of the IRP, which is the measure of lower esophageal sphincter relaxation and EGJ opening. It's actually a surrogate for the intrabolus pressure that's forcing the sphincter open. But also DCI, so how the esophagus is responding, gravity. You lose gravity, the esophagus doesn't have to work as hard. You can also see subtle abnormalities in anatomy that occur when you change that position. So in the Chicago 4.0, we did ask for a more expansive protocol, and I think that was very important. So in terms of what I meant about the conclusive and inconclusive diagnosis, I do think there are a lot of these patients that we see, and I see these patients every day in clinic, where I'll look at the manometry, I'll get my history, I'll see the endoscopy reports, I'll get a manometry, a flip, and I still don't know what's going on. These are not uncommon situations, and that's why we really need to use these complementary tests. If you require a complementary test to improve your ability to diagnose patients, that should not be viewed as a failure. But I think over the years, many people have gotten into camps regarding esophageal function testing, where they didn't think radiology was helpful and they thought only manometry was helpful and vice versa. And I think what we're finding is that all of these tools are complementary. And really that was probably born out of the fact that when we came up with this measurement, the IRP, and I take somewhat blame for this, is that a lot of people want clarity with a number. And they really wanted this number to be a dichotomous cutoff, that if you were above 15 millimeters per mercury, you had achalasia, and if you were below it, you didn't. Now, the primary problem with that is that that's not a dichotomous yes-no. It's a regression. It's a log curve, a sine curve, where all it's telling you is that the higher the IRP is, the more likely it is that you have achalasia. And you can have achalasia with an IRP of 10. I've seen people with achalasia with an IRP of 5. It's extremely rare. If you had to bet that that person had achalasia, you'd probably bet against it. But nonetheless, it is a regression and probability assessment, not a line in the sand. And that was really the impetus for really looking at these collaborative complementary tests. Now, for those of you not familiar with flip testing in the middle, we'll talk a little bit more about that later on. But the goal here is that if you see something inconclusive on manometry, most people have access to a esophagram. Get an esophagram with a barium tablet, and that will answer a lot of your questions. So I order probably as many esophagams in my practice as anyone else in the entire hospital. And even though I am considered someone who loves manometry and loves flip, esophagram is a very important tool and sometimes is the adjudicator of whether or not that person will actually go to surgery. So very important to keep that in mind. So in the end, we know that the Chicago classification is not perfect. We know that achalasia is good. We're pretty comfortable with that. I think the subtypes, we've done a pretty great job at that. But EGJ outflow obstruction should never be diagnosed on manometry alone. There should always be some adjudication with either an esophagram or flip panometry. Jackhammer. We didn't do a very good job with jackhammer in 3.0, and to be honest, I don't think we did a great job in 4.0. I don't think we did anything really. And I think, someone agrees. And I have to say that, it's a consensus group, and people always think that maybe my opinion gets voted more than other people, but I get voted down all the time at Chicago classification. And in my world, when I look at jackhammer esophagus, I would say 90% of those are normal. And then probably out of the 10% that are abnormal, probably 9% of those are related to a hernia, and there's 1% of those that are truly a motility disorder. And I think you can glean that if you look carefully at the topography and the images, but once again, they thought that that was too much, and they cut me off, and that's why jackhammer basically stays the same. I do like the fact that they made IEM a little bit more important, and now it's more of a marker of poor bolus clearance, because I do think that's extremely important in reflux pathophysiology. But that being said, I think there's a lot more work to do. So what's next? Well, one of the glaring deficiencies in all of this is that we've had this technology of impedance. And for those of you who remember Don Costello, unfortunately passed away. Don was a big proponent of impedance, and there's a lot of value in impedance that just purely gets neglected in terms of these particular tools. And I do think you're going to see kind of this turnaround to really look at this. In addition, I think the other thing that's really important is geometry. What are the luminal dimensions and the mechanics of bolus transport? I think that's something that we've lost. And that's really where I think Chicago 5.0 and flip Phonometry will help us. So I stole a concept from our speech-language pathologists in terms of how they deal with a swallow. And if you ever read a speech-language pathologist or look at the way they dissect whether or not someone has an issue with their soft palate, their tongue, their pharynx, they like to break up the oropharyngeal swallow into components. And one of the things that I noticed over the years was that when you actually looked at these beautiful renderings of these Klaus plots, there were these very distinct landmarks, and they have to have some reason for being there. And one of the things I noticed that the upper esophageal sphincter opening, when you ram that bolus into the esophagus, that's like esophageal accommodation. Just like the stomach accommodates for a meal, the esophagus has to accommodate for that bolus. So very important. So if you have a stiff esophagus from EOE, or an esophagus that's filled with liquid from achalasia, you feel it up in your throat because your tongue and pharynx are trying to ram it into that tight esophagus. And then there's this time of compartmentalization where the striated muscle just kind of delivers the bolus into the smooth muscle esophagus. That's that transition zone that you see right here, this beautiful trough that we see all the time. And then the smooth muscle takes over, which is completely involuntary. We don't know anything about it. It just happens. And then seamlessly pushes that bolus down into the stomach with a little bit of help of this kind of ampulla, which is kind of this ricochet part of the lower esophageal sphincter, which distends like a water balloon and then allows it to kind of decompress and empty into the stomach. Sometimes people call it a hernia, and sometimes it can be a little bit of a sliding hernia that becomes part of that. But it's a very beautiful, elegant, compartmentalized, component-driven swallow. And we've largely ignored that over the years, and I think that's been to our detriment. So what are we doing now? Well, there is now this large influx of technology looking at impedance and how this can help us. And some of this work originally came from an Australian group and a group from Belgium who really focused on trying to incorporate impedance into manometry in a much more robust way, and really taking the concepts that Don Castell brought out, looking at bolus clearance in the context of motility, and really made this very sophisticated with something called AIM, and it's really automated impedance manometry. And what they looked at was actually looking at impedance and motility at the same time, and they brought back tracings in a very elegant way. And one of the things that I was struck by with this technology was the fact that they were using the inverse of impedance to show volume. But they were looking at this, in my opinion, in a different plane, the wrong spatial temporal plane, but nonetheless, this was very innovative. And when I saw that, I immediately thought to myself, well, we could probably leverage this to look at different things in the esophagus and take some of the concepts that Don created and make them a little bit more mathematical and maybe clinically relevant. And we did that. We actually looked at how much liquid would either leave the esophagus after a swallow. So we call that the esophageal impedance integral. This is what you see in these yellow and pink plots. We could actually tell you how much volume is left over. And then we can also tell you whether or not the esophagogastric junction opened and how wide it opened and whether it opened sufficiently enough to empty. So we started thinking about these particular technologies as a way to better define motility. And then our colleagues down in UCSD came up with this other concept of distension plots, starting to look at how the esophageal wall distends and how this could potentially allow us to look at maybe restriction, functional dysphagia, whether or not people are feeling a stiff esophagus. Maybe the walls are too muscular. Maybe they're too fibrotic. Maybe this is what happens as we age. A very elegant approach, and I'll talk a little bit about this later on in the DDW abstracts. And recently, we've come up with a new technology called four-dimensional manometry, where instead of just doing high-resolution manometry with impedance, we've now converted things using those techniques that I learned from the team in Adelaide to look at volume. So now what we can actually do is look at a three-dimensional rendering of the esophagus, just like an esophagram, and a simultaneous manometry. So what this allows us to do is see how much liquid is left in the esophagus. It allows us to look at those patterns of emptying like we talked about. And it gives us more accurate measurements of intrabolus pressure. And then we can do some fancy biomechanics to really get a hold of whether or not this person truly has an abnormality in bolus transit. But that being said, we still get to this point in the algorithm of dealing with these particular patients where you get to the end of your endoscopy, and about 50% of the time, your patient has a negative endoscopy. And I'll tell you, one of the worst conversations I have with patients who come to see me is when they actually have a negative endoscopy, because I walk into recovery, and I tell them that it's negative, and they're always disappointed. I always look at the bright side. You don't have cancer, you don't have something horrible, but they want to know why they're having symptoms. So when you walk into that recovery area and you say, oh, your endoscopy was negative, they're always like, well, what's next? What's going on? And really, that's where I think we can make a major improvement. And that's really where this technology's come to play. And this is actually the functional lumen imaging probe. And I like to talk about this technology because I've been working on a similar device since 2001. So the first iteration of the FLIP, which is the functional lumen imaging probe, was actually a modified barostat, where I would actually sit in the fluoroscopy suite, put a barostat into people's esophagus, put my foot on the fluoro pedal, have them swallow barium, and take images. And with doing that, I could actually measure something called distensibility and the opening of the esophageal gastric junction. Because my hypothesis during my early years was that if it opened up wide, you'd have reflux. If it didn't open up very well, you didn't. And it's striking because I actually come from a long line of plumbers. I grew up in Brooklyn, New York. Half my family are plumbers or electricians, and I kind of stayed in the family business. So I really just look at whether or not the pipe is clogged. Do I prevent retrograde flow, or do I allow forward flow? So really, when I was looking at this particular technology, I was thinking about it in that way. And I subsequently came up with something that allowed me not to do barium swallow, something called the hydrostat, where I filled the bag with renographin, so this way the patient didn't have to swallow that. And eventually, a clever group of investigators came up with the functional lumen imaging probe, and because I had some patents on this conceptual model, they asked me if I would join their team and work with them to help evolve this technology, and that's really where this complete FLIP protocol came to play. But it was interesting because when I was doing the raw data analysis of these studies, I would see these weird tracings that looked like almost like a brain image or EEGs, or EGGs if you're working in the stomach, where you'd see these tracings. And for me, I hated these. I wanted to look at the mechanics of the wall, so I was doing all these filtering exercises to get rid of this. But eventually, I kind of looked at this and realized that this was peristalsis. And what I did was I took a page from Ray Klaus, and I converted this to color topography, just like he did in manometry. And what you see here are beautiful peristaltic waves propagating out the esophagus and EGJ opening. So essentially, this was a mechanism to do manometry while the patient is getting endoscopy and sleeping. So you could market this as painless manometry. How many people in the audience have had a manometry? How many people would do that again for free? Yeah. I'll tell you, getting someone to come back or do research with manometry is almost impossible. It's a horrible study. I've had it 8 times, and it is brutal. So if you had a technology that did not need to have the patient come in unsedated and have something rammed down their throat, it's like getting an NG tube, but it's sitting there and having you try to swallow. It's pretty torturous. So really what this allowed us to do, we were excited. We could actually stimulate secondary peristalsis to assess peristalsis, the muscle function in the body, and also see how the EGJ opened. And really where this was even more cool was when we started actually looking at these images here. Let's see if this goes. There we go. And one of the things that struck us is that when we actually put this down and we're watching this, this synchronized with respiration very well. So what we feel like we found here is that we inadvertently found the esophageal pacemaker. So by distending this bag, you elicit volumetric distension, and it triggers secondary peristalsis. But it does it in such a way that it is a rhythm that is almost a housekeeper wave that correlates with respiration. So when we actually looked at the important components of this, we saw that there was a lot here. There was a lot we could glean from this. We could assess peristalsis. We could assess EGJ opening dynamics. We could also assess the stiffness of the wall in EOE and other disease states. And we thought we could potentially guide surgery. We could actually put this in the OR, and the surgeons could look at it and see, well, did they do a good job at their myotomy? Did they close the sphincter up enough during their GERD procedures? And we thought this might be a tool that could really help us. And this is just another example. So the top panel is a normal person, beautiful sequenced contractions in a rhythm, and the bottom is an achalasia type 3. You can see these retrograde contractions that are chaotic. You lose inhibition in achalasia, so you can actually have a contraction every time the respiratory center fires. At least that's our hypothesis. So what we were able to do, just like high-resolution manometry, is put this into conceptual models along figures. So what you see up here in the top is a beautiful normal control, and this is what we see. We've done 35 controls, and this is the pattern that you see in control patients. This is someone who has a little bit of borderline contractions, has a couple of antegrade contractions. Here's someone with achalasia with a little bit of type 2 pattern with some of these chaotic contractions. And here's a scleroderma patient. No peristalsis and a wide open EGJ. And then we saw these spastic contractions that we actually would see in the context of normal motility. And really what we believe these are related to, these actually may be these secondary contractions that are related to hiatus hernia that is underappreciated. So really what we have now is a way to perform motility testing while the patient is asleep and actually do exactly what we do on manometry. So here's just some data showing a very nice correlation between the peristaltic patterns and DCI on high-resolution manometry. It also helps us in terms of the prediction of the number of normal swallows that you would typically see on someone or the number of failed swallows. So very nice correlates with high-resolution manometry. We've also shown that you can do a very good job at measuring the function of the lower esophageal sphincter in EGJ opening by actually making distinct measurements very similar. So the top panels are high-resolution manometry, and the bottom panels here are flip panometry. And really what you're seeing is EGJ opening abnormalities. And we showed that this did a really good job of picking up and distinguishing obstruction in both achalasia and EGJ outflow obstruction. In fact, if your distensibility index, which is your cross-sectional area divided by pressure, is above this value of 3, there's no way you have an obstruction there. That EGJ is opening up pretty easily. We've done other fancy modeling studies now looking at higher level data. This is something that uses something called K-nearest neighbors, where you can actually predict the probability of an obstruction with this particular technology real time if you have the technology in your lab. And the other thing we showed was that it actually beat high-resolution manometry. So this red and blue curve here are the measures that we use in flip panometry. That is the max diameter and the distensibility index versus both the supine and upright IRPs. So you can clearly see that those two measurements were much more effective in predicting abnormal obstruction on esophagram using a third objective tool. So just as I mentioned, we have the ability now to look at this same way as high-resolution manometry without subjecting the patient to a transnasal catheter intubation. And you can pretty much glean many of these patterns that are the same. So on the top are high-resolution manometry, and on the bottom are actually flip panometry. And I'll tell you, when I first came up with this concept, I would show this to world authorities in esophageal motility. And I wouldn't tell them that the bottom panel was flip. I would say, what's your diagnosis? And they'd be like, well, that looks normal. It's like, okay, what's this? And they said, it's achalasia. What's this? I don't know, it's a spastic motor disorder. So very easy to interpret. The learning curve is steep. So this is how we use flip panometry, and this has become a pretty standard approach in our practice. And my hope is that this moves away from esophageal practice and really into general GI, because this is something that should be done during that index endoscopy. So you scope the patient, the endoscopy is negative. Instead of going out and seeing them in recovery and telling them you got to come back for this horrific manometry, You could have already done the flip and show them that they had normal motility, put a wireless capsule in, and essentially ruled out or ruled in one of the major players during that index endoscopy, and saved them all of the hassle of coming back for multiple tests and multiple clinic visits. So this is something that should make its way into clinical practice across the board during that index endoscopy for either chest pain, dysphagia, food impaction, especially when you have a negative endoscopy. And this is kind of our conceptual model that we're putting together, and it works pretty well. And the other thing that's great about this is it lends itself to AI, which we'll talk a little bit more about. But really, you can look at these particular patterns, and it can spit out a diagnosis for you almost instantaneously using AI, focus on those topography images. This is actually a really nice example. I just love showing this example because the top panel is EOE. So this was untreated EOE with a rigid, narrow caliber esophagus. And then this is the bottom flip after budesonide and dilation therapy. You can see the motility actually comes back and the diameters improve. It's a very nice tool. I'll tell you, I've missed strictures in the past at the EGJ. When I've done my endoscopy, I've dropped the flip down and you see that restriction there. And then I'll do an empiric dilation, but instead of it being empiric now, it is actually directed because the flip has showed me that I missed a 14 millimeter stricture. So where do we go from here? Well, there's a lot of things that we can do with math. And I'll tell you, when it really comes down to it, math can solve pretty much anything. And if you really apply physics and math to problems, you can get answers. And now what we're doing is we're taking this a step further. And what we can do now with this is that we can actually plug in the information we get from the flip, the volume, the diameters, the pressure changes, and we can predict things that are really important, like work and power. So what you'll probably see is this evolution of power and work for the esophagus. We can actually say, is this esophagus working appropriately? Does it have enough power to open up that fundoplication if you do that operation? Is this someone who's going to get into trouble, who's not going to be able to generate enough power? So this is pretty much the future, and we've actually done some work already and have shown that we can actually predict this in specific patient populations. And you can see that the estimated work required here in the corner is extremely low in scleroderma to open up this weak lower esophageal sphincter. So this is proof of principle, but this is evolving at a very rapid rate. And this is really the next step in technology, and I think this is going to permeate through everything that we do. So probably about 9 years ago, we started working with some in silico models. And this was our first model of the virtual esophagus. So really, this is based on this spring gauge model that we came up with. So we created this. It took us probably about 6 months of just running it on a very high-level server computer, thousands and thousands of computations per second, to try to come up with this little cartoon here. And what this cartoon allowed us to do was to play around with the esophagus. We could make the wall stiffer, we could make the muscles work faster, we could make the muscles thicker, we could change the arrangement of the fibers in the esophagus. And these are just some examples where we took the mucosa out. We could actually see what the esophagus would look like without the mucosa. We can stiffen it up, and it gives us all of these really beautiful mathematical renderings. And we've evolved this now a little bit more so that now it looks a little bit more like an esophagus. And this is the beautiful thing about computational power. The further you get along, it changes yearly and it almost grows exponentially. So now our esophageal models look a little bit more like the esophagus. And you can see these two particular examples. And this is what the esophagus looks like normally here. It's very subtle. But this is what it looks like with panesophageal pressurization. So really where I think the future is with this particular approach is really in this next conceptual model. Let's see if we can get here. Because now we can actually ask the virtual esophagus questions. So one of the things that we found was that when people would get myotomy with achalasia, there would be a mechanism of failure that we labeled the bomb, blown out myotomy. And it's actually a very severe complication of achalasia, because if you develop a bomb and you're not emptying and you're symptomatic, the next step most of the time is esophagectomy. So it is a catastrophic component of achalasia failure. So we were very concerned about this and why people were developing this. We actually published a paper in GI Endoscopy just explaining that it exists and at a very high prevalence in people who fail myotomy. So what we did was we asked the virtual esophagus to run all of these various simulations to pick the perfect operation to prevent the bomb. So what we did was we asked the model to vary the length of the myotomy. So the standard Poem myotomy or Heller myotomy is pretty long, usually 8 to 9 centimeters. They go 2 to 3 centimeters below the SCJ, and then they go about 6 centimeters above. So we gave that to the model, said, well, what if you give it a door? You cause a little bit of restriction, no door. What if it's a partial? If you go through the circular muscle only or all the way through the circular and longitudinal muscle? And we had it run all these simulations, and then we did it based on the specific subtype of achalasia and the pattern of obstruction that you would see. And it literally spit out that the best operation for achalasia is a short myotomy that is 3 centimeters in length, that is not associated with any restriction from a door fundoplasty, and that was actually best in the context of type 1 and type 2 achalasia, which actually, if I had to design something like that, that's probably what I would have guessed. But the thing that was actually even cooler about it was that although we had been telling people that if you have an EGJ outflow obstruction or evidence of peristalsis on your manometry, that you would actually have a better prognosis because that was early achalasia. What the model told us was that no, that was actually the opposite because you're delivering too much liquid into that myotomy and stressing the wall. And in fact, when we went back and looked at our data, we actually showed that that actual peristaltic contraction that was left behind was indeed generating that particular bomb. So I think we're in an era now where we're going to see this more and more. So we've got a virtual esophagus now, and we've got a virtual stomach that we're developing, eventually a virtual anorectal junction. We're working with cardiology now to do the same thing in the ventricle, the left ventricle and the right ventricle. In fact, to be honest, I stole most of what I do in terms of the esophagus from cardiac physiology. So it's only fitting that we help them with these particular parameters. But I think the new world, as we go through this, is going to have these particular models help us. We'll be able to input scenarios that we think may be either beneficial or harmful and to test that. And really where this is really great is that we can possibly move some of the work that we do in research away from torturing human beings, because that's what I do. As a human physiologist, I literally stick balloons and catheters in people, and I watch them gag, and it's really horrifying. But yet, you know, I think many patients are willing to help you if it means that they're going to help their disease state. But in the end, this is really where the future is heading. And I think in 5 to 10 years, you know, I think people like me, an esophageal expert, will be obsolete. And really what we're trying to do is put all of this technology in the hands of the people who are actually seeing the patients so that you don't have to have the patient drive 90 minutes to see me. You know, you'll have all of this at your fingertips. So I'd like to thank you for indulging me. I left a little time for questions, and obviously we have a break period too for about 30 minutes, and I'll stick around and answer any questions. But I do think the next 5 years are going to be extremely exciting in medicine in general, but also in the esophagus. You're going to see an explosion of technologies, and you're going to see this bridging of in silico, artificial intelligence, and machine learning with what we do on a daily practice right in our hands. So thank you very much.
So before the Chicago Tribune carries the obituary for HRM, do you think payers are going to pay for this? Number one. Number two, we have an interesting question. Yeah. Any difference with sedation that's given with EGD in terms of its impact on the reading?
Yeah, so the second question I'll deal with first, because that was something, of course, we were worried about. And I'll talk a little bit about this later today about the opioid esophagus. We worry about the opioid esophagus because opioids can actually affect peristalsis. It can make it a little quicker, and it could also affect lower esophageal sphincter function. And this was something that we definitely were worried about. And when we originally did it, because these patients typically get Versed and fentanyl, which both can affect the esophageal motility. But when we went back and looked at it, and once again, I told you I do horrible things, we actually did unsedated flips and unsedated manometries on the same people to see if it would change anything. And thankfully it didn't. I actually did one myself. It was horrible. But that being said, it didn't change anything. But the other thing that was actually even better proof that it doesn't affect it is that when we actually went back and tried to compare it to high-resolution manometry, we were able to predict motility patterns pretty well. So it really didn't matter. So even if it was affecting it in some way, it didn't alter our ability to predict what motility pattern they would have most of the time on high-resolution manometry or their esophagram. In fact, it actually correlates with esophagram better than manometry. And the reason for that is it's almost like a static esophagram with a pressure sensor. So now the next question is payers. What are we going to do with payers? Well, I mean, they'll look for any reason not to cover something that actually works. And I bring up, because this is an esophageal state-of-the-art, look at wireless pH capsule monitoring. Look at the flawed payer mentality with that. You have to have a negative endoscopy to be approved to get a wireless capsule reflux test, right? So you have to bring that person back then for another endoscopy, which costs them more money, and then put the Bravo capsule in to get that person reflux testing. Whereas if you did it during that index endoscopy, you would be able to stop inappropriate PPI utilization about 40 to 50% of those patients and save them money. But why don't they care? Because they know that most people change payers every 1 to 2 years. And they don't want to pay for anything up front. They don't care if you save money over their life or you make that person better over 10 years. They only care what the cost is during that first 1 to 2 years. So in our models now, what we have to show, and you know this stuff, is that we have to show that it's going to reduce costs in that first 1 to 2 years. So how does it reduce costs? Well, they don't have to get a manometry about 40, 50% of the time. They probably reduce clinic visits, 1 or 2 clinic visits. So you have to convert that, and there's a sweet spot where that cost has to come in lower than those 3 things, the 2 clinic visits and that manometry at 50% of the volume. So that's really where it comes into play. So I'm hopeful that they will, because if you think about it, if your patients knew that you had an option of sending them for painless manometry, and then you decided to send them for painful manometry, they're not going to be very happy with you. So, I think, when you really think about it, and especially since they have to get the endoscopy anyway, it's just a piggyback, right? I mean, they're there, they're sedated. This test takes 5 minutes. If you could put a Bravo catheter down, you could put this down, and you just sit there and watch it blow up and see the response, and then you're done. So I think I'm not going to predict anything because you can never tell with payers, but it makes absolute sense that this could be a cost-effective and very patient-friendly approach to assessing dysphagia.
Thank you, John. I was going to say, you're probably making our board exam questions harder, but you're going to make patients' lives better, so we really appreciate it. I don't see anybody else standing at the microphone, so we'll conclude at this session and take the break. Please visit our exhibitor area in the back, and we'll be back at 10:15. Thank you, John.
Thank you.